Thanks so much, everybody. Like was said before, my name's Grace Meier. I'm a family medicine trained physician, but I've been working in genetics and metabolics for the last 4.5 years as an attending. But I've been at this clinic since 2017 in some capacity. And today I'm going to tell you about CODAS syndrome, which is a condition that is exceedingly rare that we do see here at the clinic. And these are two of our patients, Josiah and Javon, that have given us permission to use their pictures and their story. And so you'll see them frequently throughout the presentation. But two little boys that have this condition that are well known to us here and that we all help care for. Um, so. Just to kind of give you some context, because I do realize this is different than the typical medical practice. This was our office up until April of 2024. So my office was actually right here, and it used to be the formula and amino acid closet, but was turned into a very adorable little office. So the clinic was started in 1989 by Dr. Holmes Morton and his wife Carolyn, who had left the Philadelphia area and wanted to help the Amish and Mennonite community. They knew that there were some kind of unknown and underserved populations of specific genetic conditions in the area. And so since 1989, over the last 35 years, the clinic has really grown now to have four physicians instead of just one. And I'll tell you a little bit more about us. So, in the last year, we have a large lab in-house. The whole basement of our new building is a lab. We've run over 4,500 genetic tests in-house. We've discovered 24 new variants in the past year. We manage over 450 known genetic variants, and we are primarily funded by the Amish and Mennonite community. And so part of what our goal is to save them money. So in the past year, by navigating the healthcare system on their behalf and by taking a lot of this on ourselves, the last year's savings would be about $112 million for that community. So this is our new building. It's about 4 to 5 times the size of the old building. And again, we've grown to be four physicians. We're of various specialties. So I'm family medicine. We have a pediatric neurologist and then two pediatricians, all who have an interest in learning more about genetics and metabolics and bridging that gap for folks who are really underserved otherwise. We're located in Gordonville, Pennsylvania. This is kind of the heart of the Amish community in Lancaster County. So we're about 15 minutes east of Lancaster City. That puts us about an hour and 15 minutes west of Philadelphia, just to kind of orient you. And again, really the concept of our practice is that we're a medical home for these patients. So over 90% of the patients that we see are Amish or Mennonite, uninsured, self-pay. And again, we're caring for clinical, laboratory, and then we do a lot of research at our facility. So one of the main articles that I used for this presentation, it's included in um, my references at the end, and the article that Dr. Tossi read beforehand is actually from our group at the clinic. And my mentor, Dr. Kevin Strauss, is the lead author on that and has really done a ton of the work since starting here in the early 2000s. So just kind of a timeline. And then just a few final things about what the clinic is known for, because we do a lot of external consults of other centers from around the world. We're a newborn screening referral center. The two main conditions the clinic was founded to take care of would be glutaric aciduria type 1 or GA1, and then the other one would be maple syrup urine disease. Um, so this is kind of what our work has been in GA1, that in the time that it was found when Dr. Morton came out to Lancaster County, about 94% of those patients were undergoing permanent brain injury, um, acute striatal necrosis in the first 2 to 3 years of life. That's that susceptible window is really in the first 2 years. And in that time, Dr. Morton and Dr. Strauss worked to create a metabolic formula for that condition, which, in addition to giving supplemental carnitine, has resulted in preventing injury in just about 95, probably is what we would say about now, 95% of patients can get through that window. The other condition that we really work on is maple syrup urine disease. So this is a baby who's epistotonic and in um, acute metabolic encephalopathy from MSUD. And again, this is a condition that we've worked extensively on the metabolic formulas for. We've been a champion of liver transplant for this condition, which cures it by replacing 10% enzyme activity. And then we've also been a part of creating a gene therapy, which is been successfully tried in a bovine model and hopefully coming to humans soon. So today we're going to talk about CODAS. Definitely not a condition that we see as much of as GA1 and MSUD, but something that we see way more in our Amish community than most of the skeletal dysplasia clinics at large. I have a lot of interesting things to say about this, but fortunately, Dr. Tossi did try to hone this to skeletal findings, and so I will do my absolute best, not being either an orthopod or a radiologist, but hopefully you all will take something from this. So CODAS stands for Cerebral Ocular Dental Auricular Skeletal Syndrome. And hopefully this is the most words you're going to see on a slide of mine because I don't like words. But cerebral, meaning that there's usually cortical atrophy, immature myelin, corpus callosum hypoplasia, and variable intellectual disability. Ocular, seeing cataracts that arise between the ages of 2 to 6 months of life, and ptosis. Dental features would include delayed tooth eruption and unusual cusp morphology, auricular malformed helices that kind of create a crumpled shape of the ear, and hearing loss. And then the skeletal features, including short stature, hip dysplasia, vertebral clefts, scoliosis, and genu valgum. So this is really a brief and non-comprehensive list of the features that we see in CODIS. And so I have this additional box with even more words that this is not how we're going to learn this, but just for the sake of completeness, have this list here of all of these features. So other things that you can see, and again, you won't see all of these features together, but you can see kind of constellations of them depending upon the genotype that you're working with. But bilateral vocal cord paresis in the particular variant that we have in the Amish community, that's unanimous across the board. Those kids have, I would say, beyond laryngomalacia, but not all variants have this and end up with tracheostomy early in life. Hypotonia from birth, craniofacial malformalities, including flat face and a prominent nasal groove, the tip of the nose, cardiac defects that can be between mild and lethal, omphalocele and perforanus, fistulas, and seizures. Again, you're not going to see all of these at the same time, but depending upon the domain of the gene that you're looking at and whether the patient is a homozygote or a compound heterozygote, we'll kind of get into the different features that we tend to see and what predictions you can make. The other things I wanted to talk about in terms of CODIS would be this gene called LONP1. This is the diagram of LONP1 from a 2015 paper from Dr. Strauss, so the group that I work with at the clinic. And at that time, this was the first time that LONP1 was associated with CODIS syndrome. Prior to that, when the condition had been first described in 1991 all the way through 2015, we didn't have a genetic cause for it. So it really was just a grouping of clinical findings that we were seeing and couldn't group and fit into any other category. At that time, all of those mutations were in this AAA domain, the ATPase domain of the gene. And some other things I wanted to tell you about this gene would be that it has a variety of different functions, even within this AAA domain, and then the other domains, the proteolytic domain and the end domain, that this ATP dependent mitochondrial lawn protease can help regulate various cellular activities, including DNA replication, membrane fusion, signal transduction, transcriptional regulation. And it contributes to mitochondrial proteostasis by eliminating misfolded and oxidatively damaged proteins and supports cell viability during stress. And so it really does play critical roles in multiple mitochondrial functions for the cell. And there are other conditions that present similarly, although CODAS does not classically present as a mitochondrial disease. So to run through the acronym, the mnemonic, with a little bit more detail this time, we'll start with cerebral. So here we see a sagittal and an axial cut of a brain MRI, and you can see in both this cortical atrophy and a small brain, immature myelin, corpus callosum hypoplasia, which what happened to my, can you see my cursor? Corpus callosum hypoplasia. And then really
Yes,
very,
I can.
oh, perfect. Great. Thank you. And then variable intellectual disability. So some of these kids are profoundly disabled. And again, in our population, the vast majority, if not all of them, have a tracheostomy and so communicate by sign language. But there's really a huge progression, a huge variability in how mild or severe the intellectual disability is associated with this. So I have kids that are, always in an Amish special school, so that would be like a special needs program equivalent. And then I have ones that are communicating in sign language and drawing pictures and going, through a pretty typical school program. So really quite variable, even within our own homozygous recessive mutation that we see. For ocular findings, cataracts arising usually between the ages of 2 months and 6 months. This is pretty much unanimous across all of the mutations that I came across in the literature. And then also ptosis, that was more variable finding. This is again one of our patients. For dental findings, real delayed eruption of the teeth, so somewhere between a year, 2 years behind even. And then when the teeth do erupt, they have these um, unusual cusp morphology changes, so pointy extensions of the teeth, which are kind of hard to get pictures of exactly. But here's one of them that you can see. And then here's some more down here on the right side. The thing is that a lot of these kids end up getting um, oral traumatic ulcers and sores from these teeth that have these sharp cusps and also that stick out in various directions. And so a lot of times that those under anesthesia are filed down so that they're not dangerous to the child anymore. So it's hard to capture pictures of these before that happens. For auricular findings, you can see this malformation of the ear. So the helix kind of crumples into the anti-helix. Here's a normal ear just for comparison. And here you can see Javon and Josiah playing together and that they both, from the side, have this crumpled ear deformity. I guess one other interesting thing to share while we're looking at this picture, and you can see their trachs and Javon's G-tube, is that there have been times where the baby's trach has become disconnected from the vent, and even as just a little toddler, maybe 2, 3 years old, that Josiah would quickly alert his parents that there was an issue on the baby's behalf because he knew how critical that was from his own experience. All right. And then as far as skeletal findings go, first off, I just included all of the ones that are on OMIM, and we're going to go through all of these findings. Um, but just wanted to provide you with a list. So again, we're going to talk about delayed bone age, hypermobility, persistent vertebral coronal clefts, odontoid hypoplasia, scoliosis, the squaring off of the iliac bones, the differences in the hip joint, and including dislocation in some of those patients, variability depending upon the variant that we're talking about again, and whether they're homozygous or compound heterozygous, as to whether we're going to see short stature and how that's going to affect the long bones, delayed ossification of these bones, hypoplastic or absent. Um, Epiphysis of the bones, again with the shortening, sometimes total absence of long bones, and then differences in the hand bones, including delayed carpal ossification and proximally placed thumbs, which is pretty rare. All right, so here we're going to talk about delayed bone age. So the upper left shows a 4-month-old's hand, and then the upper right is a 30-month-old. And you can see the clear epiphyseal delay, but without any real morphologic anomalies. Um, then we're going to go to the next slide. Here's the better look at these coronal clefts. So depending upon your specialty, you may be much more familiar with this than me, but I have learned that vertebral coronal clefts are something that we see in most fetuses, and into the newborn period, they can persist. And so that's that lucency right here on the vertebral body. And that in CODAS syndrome, um, a lot of times with ossification issues, we're seeing these lucencies persist way past the expected time that you would think that you would still see them. And so this middle picture and then the picture on the right are of older children. They're both 1 year old and then 4-year old, and they still have some lucency in here. And the area of the spine that you're generally going to see these in older children, like this 4-year-old, would be between T11 and S2. Here's a picture of one of our patients with scoliosis. So this is a 5-year-old. These kids undergo extensive bracing. So in reviewing the charts of these boys who we have so many pictures of, it gets up to them being braced almost 24 hours a day before they end up undergoing rod placement. And then over here, you can get another view on this abdominal x-ray of the scoliosis and also the persistent vertebral clefts. Next up, we can appreciate the squaring off of these iliac bones. So just to orient everyone, the top 4 x-rays are all of patients with CODAS. The bottom left is a typical healthy 4-year-old, and the bottom right is a typical healthy adult. And so I think especially when you compare how round these angles look here and how you can kind of see this shelf-like feature of these iliac bones, you can appreciate that they're a little more squared off. Other things to know about these radiographs. So again, these patients are in increasing order of age. So 8 months, 4 years, 4 years, and then 5 years old. And the other thing that I want you to appreciate about these slides are the shortened femoral necks. So here you can see a nice normal one, and here these are much, much shorter, if not almost non-existent over here. And the irregularity of the acetabular part of the bone, and also just the lucency of this bone and how it's really not ossified. The way that you would expect it to be for the age. This x-ray, we're going to try to appreciate the genu valgum, which you can see right here, and then also the Metaphyseal dysplasia, most evident in the hip joints. Again, you can see all of this lucency in here. And then delayed ossification of the epiphysis as well. This slide, we're looking at the chevron sign. Many of you may be familiar with the chevron sign from achondroplasia, and this chevron sign is a little bit different. So most easily appreciated at the distal femur. In CODAS syndrome, this chevron sign is more centrally located and more of an acute angle than what we typically see in achondroplasia, which is covers more distance from one side to the other of the distal femur. So more centrally located here. And then other things to appreciate. Oh, technically, when you get into talking about this in the literature, one paper did go into technically you could lump CODAS into a form of spondyloepiphyseal dysplasia, but it hasn't formally been made a part of that group. All right, so here we see hypoplastic or absent epiphysis. So the two pictures on the left are the same child. The left foreleg is short and the foot is clubbed. The distal femoral metaphyseal abnormality and hip subluxation, you can appreciate here. And then this photo on the right is an ultrasound, and this child actually is missing all of the long bones in that leg, and this is a foot attached directly to the hip. So again, as a reminder, these photos, these features, pretty much all attributed to gene mutations found in this AAA portion, AAA domain of the LOMP1 gene through about 2015, actually 2019, because we're going to get to when that changed. So, um, sorry, I lost my train of thought there, but yes, here's the mutations that we were talking about. Here is a 3D model of this gene, just so you can appreciate the different domains. And then another paper from 2015 out of Switzerland went a step further. This was again the same year that LONP1 was identified as genetic changes in LONP1 causing CODAS syndrome, that they kind of split it into three separate phenotypes that you could see within the AAA domain. So prototypical, pretty much consisting of hypotonia, developmental delay, cataracts, the dental findings, the crumpled ear, short stature, subluxation of hips, and delayed ossification. The severe, which I believe this is pretty squarely where our Amish variant falls. So it would be the prototypical features plus laryngomalacia all the way to vocal cord paresis, congenital heart defects, tibia hemimelia, and umbilical hernia. And then the last would be more mild, and that would be skeletal ocular restricted, where you'd see some variable amount of developmental delay in cataracts, but with normal stature, some epiphyseal hypoplasia on skeletal survey and delayed ossification, but none of those major abnormalities like missing long bones. Still having the flat face and some kind of grooved nasal tip, but really otherwise a much more mild presentation. So here's the case I wanted to talk about, and this won't be an easily solvable case because I have to give you more information, but I'll walk you through this. So this is actually a patient whose case came to our clinic via telehealth looking for more information. A 3-year-old from South America who had developmental regression with hypotonia at 15 months of age, was noted to have ataxia, acquired strabismus, Brain MRI showed mild cerebellar atrophy. She had developed bilateral cataracts prior to coming to us and had those removed, ended up developing esotropia, and had expressive language delay also as a regression. And like many people in this setting, hearing these regression features, my mind immediately goes to Rett syndrome in a little girl like this. Um, but the little girl had genetic testing prior to coming to us. So just so you can kind of appreciate the timeline at birth, totally typical, sitting by 7 months, walking by 13 months here. 16 months old, started having regression in walking, 24 months could only crawl, 35 months is this picture here at the end, standing with assistance, needing to hold on now. And what you can't see is her patched eye and the left eye esotropia. So she has those features, but she has normal hearing, normal heart, eats by mouth, no trach, normal skeletal survey. She has two brothers with axial hypotonia noted in infancy. One did not start at birth, so one was something that progressed. Progressive hypotonia spasticity resulting in regression around the age of 1 year. Both brothers ended up with a G-tube at age 3 to 4 years. One has cataracts, one has seizures. Both have significant intellectual disability and brain MRI showing cerebellar atrophy, no other skeletal, dental, or auricular issues to report. So here's her whole exome result that was sent to us. And you can see that she has a mutation in LOMP1, and this doesn't make any sense for everything that we just discussed. So in 2019, another paper came out, and instead of just seeing these changes in the AAA domain of LOMP1, we started to see and recognize a phenotype associated with changes in the protease domain. So in this red section over here. And I believe actually this one is, this was the case that they were talking about in the paper. But this little girl definitely squarely fits in that protease domain. So here's the paper. And what they actually ended up talking about was LONP1's role in activating, where do we go? Pyruvate dehydrogenase. There we go. And that this activity was leading to these symptoms of regression, but actually not showing full features of a mitochondrial condition, so no increased lactate to pyruvate ratio, but did end up showing that in cells isolated, muscle cells isolated in this condition, that treatment with dichloroacetate inhibited the PDH kinases. And so that's actually something that's being worked on at CHOP. And we had connected this little girl with Dr. Rebecca Ganetsky in the Mitochondrial Center at CHOP. And I actually don't have an update on if they connected and were able to come to the United States yet or not. But that is something theoretically that this kind of LOMP1 mutation would be amenable to. And these are my references.